Welcome to Season 2 of Unprivate Parts. This podcast is a space where women can feel supported and understood as we have open, honest conversations about women's health and the uncomfortable subjects we all want answers to. In this season, we will explore the complex realities of breast and gynecologic cancer journeys, breaking them down with empathy and expertise. From hearing the words, "you have cancer," to making decisions, undergoing treatments, navigating survivorship, and seeking support, we will cover it all. Nothing is off limits, and no topic is too uncomfortable to discuss here. This is Unprivate Parts.
Welcome back, listeners. I'm Lauren Smith, the Manager of Business Development here at Women's Hospital and the host of the Unprivate Parts podcast. Gynecologic cancers aren't one size fits all, and understanding the 5 types, cervical, ovarian, uterine, vaginal, and vulvar, is key to catching problems early. In this episode, we will break down the symptoms, risk factors, and screening options that every woman should know, including why Pap smears and regular pelvic exams matter more than you realize. We'll explore who's most at risk, when to take action, and how women can stay proactive even for cancers without routine screening tests. And joining us to guide this conversation is Dr. Renee Cowan, one of our gynecologic oncologists here at Women's Hospital. Thank you, Dr. Cowan, for being here. I always learn so much from you. And let's just dive right in. What is a gynecologic cancer?
Thank you, Lauren, for having me. Happy to be here and to talk about this, my most favorite topic, GYN cancers. So a GYN cancer or a gynecologic cancer is any cancer that affects one of the GYN organs. So that would be the uterus, which is otherwise known as the womb. It would also include the cervix, which is the opening to the uterus. That's what, when the doctors check you to see how dilated you are, that's what they're checking. The fallopian tubes and the ovaries. And then it also includes the vulva or the lips of the vagina. Some people also may call it the labia. And it also includes the vagina itself, which is kind of the tunnel that leads back to the cervix.
What makes each one of those cancers unique?
So each cancer is unique, just like all cancers in your body are unique. So a cancer is an overgrowth of cells. Cells normally grow, and there's a part of the cell that tells it to stop growing and when it's time to die and to be replaced by a new cell. Cancers occur when cells continue to grow and don't know that they're supposed to stop growing. And they will also grow and invade into the tissues underneath them, and then they cause problems. They'll spread to other parts of the body and basically harm your normal body in ways that make it difficult to live. And so each cancer can start from a different type of cell. So each of the parts of the GYN system can make its own cancer based on just what organ it is. And then additionally, different cell types within that organ can make a different type of cancer. So I often will explain to my patients and say, cancer comes in different flavors. Some of those flavors are more aggressive. Some of them are less aggressive. Some of them can be treated in one type of way and others need to be treated in a different type of way. And so it's always going to be really important to work with a physician who is specialized in treating these cancers so that they can tell you how that specific type of cancer should be treated. So every cancer, not just in your GYN tract, but any cancer that anyone would develop in your entire body is going to be unique and should be treated by a specialist who is familiar and experienced and an expert in treating the cancers of that body organ.
So let's talk about the flavors.
Okay.
Which are the more aggressive flavors or cancers, explaining to your average patient?
So normally we will look at each cancer type and give it a grade. A grade will often will be either grade 1, grade 2, or grade 3. We can also just categorize something as low grade or high grade. And then your doctor will explain to you that those higher grade tumors are normally more aggressive. When it comes to GYN cancers, there are most deadly, for lack of a better word, or for our cancers that are most aggressive, usually originate in the ovary and are categorized as high-grade serous ovarian cancers, high-grade serous ovarian cancers. Those are normally our most aggressive. They also are less rare, affecting 1 to 2% of the population. Our most common cancer arises in the uterus, and our most common GYN cancer is an endometrial cancer and is honestly low grade most of the time that we find it, and can be treated surgically, maybe with a little bit of radiation after, and maybe with a little bit of chemo after, depending on where it's spread and some of the other characteristics that we look into or test for. Even though ovary may be our most deadly, it is not as common, but our most common is lower grade and can usually be treated.
And who is most at risk for GYN cancers? And can you explain how genetics might influence those risks?
Yes. So each cancer comes with different risk factors. Again, let's start with our uterus and the endometrial cancers that are most common. Those are usually associated with lifestyle and lifestyle diseases because it's related to obesity, in the sense that your ovaries produce estrogen and progesterone every month during your reproductive years, and they will cycle month after month. Then a woman goes through menopause, and your ovaries stop producing estrogen and progesterone, but there are other cells in your body, namely your adipose or your fat cells, that produce estrogen. And so the estrogen that is produced by those cells still acts on the uterus the same way that the estrogen produced from the ovary would act on those cells, with the difference being there's no longer progesterone there to balance it out. And so that is a theory called unopposed estrogen. Now, it does not necessarily always correlate to how much adipose you have. Each individual is different. So you can't say, oh, I'm only 10 pounds overweight, so I shouldn't get it, or I'm 100 pounds overweight, so I know it's definitely going to happen to me. It doesn't necessarily correlate like that. And then also, even if you haven't gone through menopause, you can have extra estrogen from, again, those adipose cells that can still be too much estrogen for what the progesterone that your body is producing. And so that's a big modifiable risk factor, which is really important because endometrial cancer is increasing year after year. Those rates are increasing. And a lot of that has to do with, I guess we can call it the obesity epidemic, in that obesity is increasing and we have become more sedentary. And women are not necessarily acknowledging that there is an end, that bleeding should stop. And so that's always like, you and I talk about this all the time. And that my soapbox is about postmenopausal bleeding or abnormal uterine bleeding. No woman should bleed after menopause. And what is menopause? Menopause is the time period that is defined by 12 months with no menstrual cycle. So if you have gone 12 months without a menstrual cycle, you are in menopause. That's whether you had hot flashes or you didn't have hot flashes. Like, you're in menopause. You should not bleed anymore after that. So if you've had your 12 months and then you start bleeding again on month 13, you need to go see your GYN doctor. Additionally, everyone goes through menopause. You'll have a grandma that's like, I've never had menopause. Ma'am, yes, you have. It happens. And the average age for menopause in this country is 52.5. So if you're floating around at like 55 and still with a regular cycle, I'm not saying that doesn't mean that it's okay, because average means that half of the people go past that and half of the people are less than that. But it means that you need to have a relationship with your GYN doctor and make sure that it's okay. Make sure that you've been evaluated. Make sure that someone is checking you regularly to make sure that you're not in that population of women that's ever growing that is having abnormal bleeding that's being covered up. And then what does that evaluation look like? You don't just talk to your doctor and say, oh, okay, I'm having bleeding. And they're like, oh, okay, we'll check on it next year. No, you need an ultrasound and a biopsy. And this is really important because old guidelines just used to require an ultrasound. But multiple studies have shown that in Black women, in women with fibroids, in women with other GYN issues, an ultrasound is not sufficient to really diagnose or tell you that you should get a biopsy for the next step. You should ask for a biopsy and don't be afraid to advocate for yourself and say, hey, I read somewhere, I saw on Instagram from a reputable source like Women's Hospital that I should have a biopsy and an ultrasound because this bleeding is not normal. And so that's really, really, really huge. I can't tell you how many women come into my office and say, oh, I thought it was okay. I didn't, that it was normal to just start bleeding again in my 60s or 70s. No, it's not. I can't tell you how many women have said, oh, well, I told my doctor that I was bleeding and they said it was okay, or they said it was fibroids, or they said it was XYZ and didn't really evaluate me. And so those are things that we can't ignore. Fibroids don't just start bleeding out of nowhere when you're in your 60s. That's not normal. That's not a thing. So I've taken us way off track, but that's because I feel really strongly about
ladies.
Postmenopausal bleeding, because we can do something about it, And I've had a patient that ignored her bleeding for years, and it hurt my heart because she knew she was bleeding and she kept it to herself, and she was a well-educated, well-to-do woman who just kept that
scared?
part to her. I think she was scared and embarrassed. And by the time she came to us, there wasn't anything that I could do. And so my heart has been broken since then. And I've I've been on the soapbox ever since, that it's not okay. And so, this is something.
We are joining your fight.
Yes.
Ladies, it is not okay.
Yes, let's join in.
And how can women advocate for themselves and ensure they have a voice in their cancer care?
I think it starts with developing a good relationship with your physician. And I think that you should have a GYN physician. Every woman, every person who has a vagina should have a gynecologist. And I think that's hard. Women will often think that when they've had their last baby, their relationship with their gynecologist ends. And honestly, that's where it's just beginning. There's a whole set of life that happens. There's a whole new world out there after you've had your last baby, after you're going through menopausal and perimenopausal changes. And so you have got to have a good relationship with your gynecologist. And here at Women's Hospital, there are over 50 of them. So one of them must be able to meet your needs. There has to be somebody that you can get along with, that you feel like you can trust, because you really need to have this relationship with this person who you can tell your deepest and darkest things to, that you're embarrassed about, that you can talk about, this is dry, or this itches, or this doesn't feel the same. And I think that is really the beginning of making sure that we combat these GYN diseases.
Let's talk about cervical cancer. Is that the only GYN cancer with a routine screening test?
It is. So cervical cancer is a cancer that is caused by abnormal growth in the cells on the cervix. Again, that's the opening to the womb. And so the Pap smear is the test that was created to test for those abnormal cells. The good thing about cervical cancer is that we can often catch it early because of this screening test. So a Pap smear occurs when a provider puts a speculum into the vagina and then collects a swab of those cells. And then those cells are sent to the laboratory where someone looks at them under a microscope and tells you if they are abnormal or not. And if they are abnormal, how abnormal are they? And so just because someone does a bimanual exam or just because they use a speculum to look at your cervix does not mean that a Pap smear was done. I think often women will say, I had a Pap smear in the emergency room. Highly unlikely, very unlikely that happened. It usually happens in a doctor's office, not just by gynecologists, but usually in a doctor's office. And they say, you may want to know, did we do a Pap smear today? And so they will look for cells to be abnormal, and they will also check for HPV. HPV is the human papillomavirus. and it is associated with 98% of cervical cancers. And it also is something that is endemic to humans. Any humans that have had any sort of sexual activity of any sorts with anyone will often contract that virus. But like the flu virus or any other virus, your body normally would clear that virus on its own because of your immune system. There are strands that are able to evade the immune system, and there are people who have a compromised immune system for whatever reason that may be, that don't fight that virus. And that's what allows it to get into the cells of your cervix and create change. And that change, when we catch it early, we can prevent it from becoming a cancer.
Since there are no standard screenings for ovarian, uterine, vaginal, or vulvar cancers, what should women do to stay proactive? Is that just bringing it up with your doctor, or are there signs to look for at home? How would you say to stay proactive?
We can talk about each of them. So for vulvar cancers, you want to look at your vulva. Grab a mirror, take a look.
Okay.
Lift your leg up, look down there. You should know, and if you can't reach, you can't see, they need to get a friend or a partner to look, because you should be acquainted with what your body looks like. There's so many women who are like, I don't look down there. It's ugly. No, it's not. It's beautiful. It's yours. You need to look at it. It is. It's beautiful. You need to look at it, and you need to know what it looks like, because vulvar cancers, and they also usually start as a pre-cancer first. And they can be, maybe it's an area of skin that's itching that you can't figure. You've put all these creams on it. You can't get it to stop itching. It's an area of skin that's lighter than the area around it, that's redder than the area around it, or that's darker than the area around it. And it doesn't matter your skin color or your vulva skin color. Different cells will react differently and will look different. So your gynecologist should look at it every year, but you are your first line of defense. And so just like we're very good at talking about breast self-exams or knowing other parts of your body, you look at your teeth, you look at your face, you look at new pimples, you look at new moles, you need to look at your vulva and know what it looks like, and so that you can notice if something changes, because it's supposed to be allegedly a rare cancer. But I really find that it comes up in my practice way more than I would have expected, or more than I was taught in medical school and training. And I do think that it's because a lot of women are ignoring that area. And the vulva, the lips, the labia, that portion. Okay. For cervical cancers, what you want to do is get your pap smear every 1 to 5 years. It all depends. There's a lot of minutia about how often you get it done. But again, that's where having a relationship with your gynecologist comes in, and they will help guide you on how often that screening test should be performed. With your uterus, you want to pay attention to your bleeding, your lack thereof, or your additional bleeding. And you talk about that with your gynecologist and determine if you need extra working. The good thing about the uterine cancers is that more than 85% of them are going to present with some sort of abnormal bleeding. So that's not usually something that's just hiding there waiting for you. Now, with the fallopian tube and the ovaries, those tend to be a little quieter and don't necessarily give us the symptoms that the others might give us, and they're a little bit harder to detect. And that's why the majority of them are detected at more advanced stages. But again, when you have a good relationship with your doctor and you can talk to them about changes in your bowel habits, your urinary habits, bloating, feeling different, and when they can do a good bimanual exam, I've had multiple patients come to me from the GYNs in this hospital who have done a very good bimanual exam and have noticed a mass or noticed something. And it's something that you wouldn't think that you would be able to feel on your own. But a lot of the doctors here, because they're so experienced, can say, hey, something doesn't feel right. This is not what it felt like last year, and find something early.
Are there any new or emerging screening tools on the horizon for the other 4 cancers?
One of the things that is for ovarian cancer is that about 15 to 20% of those cancers are related to genetic mutations. And so that's another thing that we always have to keep at the forefront, again, because this is the GYN tract or system, this is something that women will often not like to talk about. And you know that you had some woman in your family who may have been sick or may have passed away from something and you're not sure, and everyone was kind of hush-hush about it. But you need to know your family history, because it might be that when you talk about this with your physician, that they say, hey, this something doesn't sound right here. We should get your genetics tested. And so often, and genetic testing is something that is often a little bit scary or taboo. But when we test your genetics and say that you have a mutation that predisposes you to have one of these cancers or malignancies, we can do something about it. We can take those ovaries out before they become a cancer, which is the ultimate win and victory, right? And then we can take your risk. Some of these mutations are associated with almost a 40% risk of developing an ovary cancer. And if we take those ovaries out, we drop that risk to 1% to 2%. So for a same day procedure. And so there's all sorts of things that we can do and have at our disposal once you know the information.
So would you recommend, if you don't know your family history, because you're right, people didn't talk about it, go ahead and get the genetic testing, or do you have to qualify?
Sometimes you have to qualify and sometimes you don't. I often, when I'm confused, will reach out to a genetic counselor. We've got amazing genetic counselors here as well, and help them to guide me. Some people do those private market tests and get information from there. What I would recommend as a first step, if you don't know your family history, is to ask. Ask your family.
Who'd have thought?
And start there. And then take what you have found to your doctor and say, hey, does this sound like I should be able to qualify? I do believe that there are programs for people who are adopted to be able to get genetic testing just based on that alone.
That's awesome. And then aside from the family history, how does age play into the whole factor?
Age, as you get older, our immune system weakens and you live longer. And so that gives you, which is the goal, to live longer, but it does increase your risk for some of these cancers as we get older.
And other factors, you mentioned obesity, family history, your age. Is there anything else?
I often talk to my patients about cigarette smoking and tobacco, because cervical cancer cells and abnormal cells in the cervix, those HPV infected cells, tobacco is candy for those abnormal cells. So every time you get ready to light up, think about that you're feeding those abnormal cells tobacco. And not just the ones in your cervix, but also the ones on your vulva, because those have similar etiologies. 60% of the vulva cancers are related to HPV. And so every time you light up a cigarette or any other form of tobacco, you're feeding those abnormal cells. So you really don't want to do that.
Are there specific lifestyle or nutritional changes that one can incorporate into their everyday life?
You just want to get me riled up.
I do. She's so passionate about this topic as well.
I am passionate about lifestyle and nutrition. I think that we do not pay enough attention to what we eat and how we move. Your body is fueled. Food is medicine. We need to increase our green leafy vegetables. We need to increase our legume intake, or beans. Yes, I know they can make you gassy. Keep eating them. Beans increase your life survival by, I think, up to 5 years. I mean, don't quote me on that. I mean, I know that we are quoting me, but yes, like beans are
quoting you.
Beans are very, very good for you. People who eat beans regularly live longer than people who don't. It's a good source of fiber. And anything that is going to fuel your body is going to do well for you in a GYN standpoint and from a GYN cancer standpoint. Now, am I saying that you can live a certain way and guarantee that you won't get cancer? No. But if you are healthy and you happen upon a GYN cancer, you are much more likely to be able to withstand the treatment. There are often times when people have cancers that I could treat if I could have surgery for them, or if they could withstand chemotherapy or radiation, but their bodies aren't strong enough to withstand the treatment, because, you know, the treatments come with their own toxicity. And so a lot of things are not just about preventing the cancer from occurring, but also putting your body in a place where if you do get a cancer diagnosis, you can combat that in combination with the therapies that we have. And so movement is extremely important. A body that stays moving stays moving. It's like, it's mind-boggling. But if you practice getting up and getting down every day, sitting on the floor and getting back up, you will continue to sit on the floor and get back up and be able to get up. Those are the things, your lower body strength, those are the things that lead to increased fragility as you age. We talked about age earlier and how that plays a role. People get weaker as they get older, and you need that leg strength for things like carrying groceries, going to the bathroom, getting off of a toilet, getting off of a chair. These are the things that people need help with as they get older. And so if you think about it when you are in your younger years, and when I say younger, I'm talking about 40s and 50s.
Absolutely.
When you think about those things in those younger years, they prepare you for life in your older years and make it easier for you to get on an examination table, to be examined. That's something else. You have patients who are not mobile and have a difficult time even getting examined, or don't go to the doctor because they don't like how high the tables are or how uncomfortable that it is.
Why do you think women are so scared to come to the doctor?
They don't like it. No one really enjoys opening their legs and having something probed in them. And have you seen the cat meme looking through the paper towel roll and the cat looks in and then they put their little mitt and they're like, yeah, that's what a pap smear is like. That's what it feels like. It's not comfortable, but the dentist is not comfortable either, but because you can see your teeth, you keep going, but no one can see your cervix. And so they're like, oh, if I ignore it, maybe it'll go away. No, if you ignore it, bad things will happen. So you should go there. And it's like momentary discomfort for a long-term gain.
Dr. Cowan, when your patients are initially diagnosed with a GYN cancer, what would you like them to know?
I think it's really important for them to know that it's going to be okay. I think that a lot of patients come to our office scared. They get a phone call that says you are needed or to be seen at an oncology office. And oncology equals fear. Mm-hmm. Cancer is scary, and people often feel like it equates to death. And we've come a far ways, and it doesn't always equate to death. Our practice has multiple GYN oncologists. We work together with cutting-edge surgeries and treatments. We have multiple medical oncologists who give chemo. We all work together, radiation doctors. We all work together to make sure that you are our primary focus and that we can guide you through this road. We're not promising you a crystal stairway. We're not promising you a smooth road. There are going to be bumps. There's going to be things that are unpleasant. There are going to be tears, but it is going to be okay. And we're going to keep working with you until there are no other options. And even in the end, it will still be okay. And so I think that if we can put aside our fear and really look at ourselves and look at our family members and have a good understanding about what life is, what love is, right? Because you're not scared if you don't love something. Then you're not scared. If you're not passionate about something, if you don't have these relationships, then you're not scared, right? And so when we can put all of that together and just come in and let us talk to you, let us guide you, we promise to try not to steer you astray. And we really are open to working with you and what your wants and your desires. Nobody's going to force surgery on you or force chemotherapy on you or force radiation on you or force hospice on you. That's another thing that people are scared about. But what we are about is making sure that you understand what's happening to you and that you are the driving force, the director of what continues to happen to you and get to be the captain of your own ship.
Be informed. And just because you are diagnosed, that's one of the questions I wanted to ask. That doesn't automatically mean you have to remove your parts or you have to have surgery.
Not all the time. Every situation is unique. And that's another take-home point, is that every body is different and every situation is unique, and it's worthy of discussion and figuring out what your needs are, what your wants are, what your desires are versus what they aren't. And it doesn't mean that, oh my gosh, I can't ever have any more babies, or oh my gosh, I can't do this, or I can't do that, or I have to have this done. That's not necessarily what it means. But also it might. And so it's worthy of discussion.
Thank you, Dr. Cowan, for helping us break down the 5 GYN cancers and for sharing how women can stay informed and proactive about their health. Understanding the differences between these cancers and knowing what to look for can truly make a life-saving difference. To our listeners, remember, you know your body best. Don't ignore changes. Keep up with your routine exams and never hesitate to advocate for yourself. Thank you for joining us, and we'll see you next time on Unprivate Parts.
Thanks for joining us for this episode of Unprivate Parts. Don't forget to subscribe to our podcast so you never miss an episode. For more women's health tips and cancer-related content, follow Women's Hospital on Facebook and Instagram. If something you heard resonated with you, please share it with others. Thank you for listening.